Targeting BCL2 with Venetoclax in relapsed chronic lymphocytic leukemia. Definition: new treatments have improved outcomes for patients with relapsed chronic lymphocytic leukemia, but complete remissions remain uncommon. Venetoclax has a distinct mechanism of action. It targets BCL2, a protein central to the survival of CLL cells.
We're coming up trying to develop combinations of these new targeted treatments to try to eliminate either in the short term but particularly in the long term leukemia, in this case chronic lymphocytic leukemia. So the overarching purpose of the research aligns with what I've just said. Chronic lymphocytic leukemia is the most common leukemia in Europe and North America. And while many patients have a good prognosis, people who relapse early after our current standard treatments or who don't respond to current standard treatments have a very poor prognosis akin to some of the acute leukemias. So new treatments are very much needed, and there's been significant advances in the last couple of years in this space. One of those advances is this drug Venetoclax, which is a tablet that's taken each day. It's designed specifically to target a key weakness in some blood cancers, in this instance chronic lymphocytic leukemia, and it works, and I'll show you on the next slide how that happens, by telling leukemia cells to drop dead. And they do this by a process that was discovered in research over 50 years ago by apoptosis. And so the idea of this study is to combine this new targeted treatment with another non-chemotherapy drug that's been around for a long time. We know a lot about it, and that's rituximab. So this slide just outlines the mechanism of action of Venetoclax. Now, CLL cells depend for survival on a protein that's within cells called BCL2. It was first discovered about 28 years ago, and its function was discovered 26 years ago, and this drug was first generated under any stress because it's got a lot of this BCL2 protein. The drug comes into the cell, it binds to the BCL2, it switches it off, and the CLL cell can no longer survive, and it undergoes a process of death, and that takes several hours. So the action of this drug is very quick. Turning to the results of the research, this trial included 49 patients, all of whom had CLL that was not doing well with current standard treatment and had returned or was refractory to treatment. Of the all of the patients received 6 standard doses of rituximab, and then subgroups of the patients had different doses of Venetoclax. All those doses worked, so they're pooled for this analysis. Overall, 41 of the 49 patients had a very good response by our standard criteria. 20 patients achieved what we call a complete response, which is when you see no evidence of chronic lymphocytic leukemia by just standard technology. Of those 20, 13, we couldn't find any CLL using very sensitive research techniques. And excitingly, 6 of the patients, in fact, elected to stop having their Venetoclax treatment, which in others was ongoing. And to date, only one of those 6 patients of mine, and it was only 2 weeks ago, hence different information in the written abstract, only one of these patients has had recurrence of disease, and that was 2 years after they stopped treatment. So this is a new targeted therapy that in combination may mean that we can have a treatment course that isn't ongoing in the long term. So in conclusion, Venetoclax and rituximab is a very active non-chemotherapy treatment for patients with relapsed refractory CLL. We've learned how to give this combination safely, and to establish formally just how much of an advance this may be, there's now a randomized study ongoing between what would be the standard treatment, which is chemotherapy plus rituximab, and the chemotherapy is bendamustine, versus the Venetoclax plus rituximab.
Applications in medicine. We conduct a phase 1 dose escalation study of daily oral venetoclax in patients with relapsed or refractory CLL or small lymphocytic lymphoma to assess safety, pharmacokinetic profile, and efficacy. In the dose escalation phase, 56 patients received active treatment in one of eight of those groups that range from 150 to 1000 mg per day. In an expansion cohort, 60 additional patients were treated with a weekly stepwise ramp-up in dose as high as 400 milligrams per day.
I spoke about Venetoclax, which is the BCL2 inhibitor currently approved in the United States only for people with relapsed refractory disease, 17p deletion patients. But I showed the data of the breakthrough designation that the FDA is currently evaluating for relapsed refractory disease, which is Venetoclax in combination with rituximab as the monoclonal antibody. And some of these patients are able to stop any therapy just because they achieve such a deep response to complete remission or MRD negativity that they are able to stop and then they're still in remission. So you don't have to take a drug forever, So it's another new regimen that we're thinking, and the majority of these patients that participated in that trial were like older than 65. So another type of regimen. So I guess the new era of drugs that just target the pathway, the signaling pathway that is overexpressed and causing the cell proliferation and survival of the malignant clone, it's much better than chemotherapy, which, it's very tough to tolerate for most of our patients, in particular patients that are elderly.
Pros and cons. The landscape of treatment for relapsed chronic lymphocytic leukemia has recently changed with the introduction of agents that inhibit intracellular B-cell receptor signaling. Ibrutinib, monotherapy, and idelalisib, in combination with rituximab, induce response in the majority of patients in a whom chemoimmunotherapy has failed, and these patients have improved outcomes. Treatment is given indefinitely, and complete remissions is uncommon, particularly in the first 2 years after the initiation of therapy. Persistent disease is a concern because of the potential development of resistance, although many responses are durable and may deepen over time. Relapse accumulate with ongoing follow-up, particularly in patients who have chromosome 70p deletions. The outcomes for patients with disease progression well received ibrutinib treatment remains poor. The toxic effects include mild diarrhea, upper respiratory tract infection, nausea, grade 3 or 4, neutropenia.
The Venetoclax is probably from the new treatments the most powerful drug we have so far, and the problem with this drug is it's so powerful that when in the first studies patients were treated with a full dose, there were some cases of severe tumor-lysis syndrome, meaning the lymph nodes were shrinking so fast and the lymphocytosis count came down so fast that there was a severe kidney damage. And unfortunately, there were even 2 or 3 patients who died because of this kidney damage. And therefore, the new regimen was developed with a slow dose increase of Venetoclax, where we start with 20 milligrams and then every week double the dose until we reach the final dose of 400 milligrams. That means so far within clinical studies for the patients that so it's an oral drug, it's not so simple as, for example, other oral drugs we have right now, because the physicians have to check the blood before the first drug and then 8 hours later if there is already an increase in a kidney value, and therefore that means for the patients they have to be very compliant They have to drink a lot of water, and they also have to be close to a physician or maybe even to a hospital when they're feeling better. Because, of course, what we are most afraid of is killing a patient or bringing a patient into danger whom we can treat very, very well with this drug, and therefore we have to be very careful at the beginning. But in our experience, usually we know there's a certain group of patients who has a very high risk developing kidney damage, and for the rest of the patients, it's not so problematic. And we will learn to have special safety aspects for this specific high risk group for tumor-lysis syndrome. So far, the drug is not yet licensed. It will be licensed in relapsed CLL, and this is a very good question because nobody knows when should we use the drug. Should we use the drug before ibrutinib? Should we use it afterwards? It will be first licensed, of course, in relapse setting, and probably especially patients with 17p deletion and TP53 mutation. Here we see no worse or no inferior activity, while we see inferior activity of ibrutinib or idelalisib in patients with 17p deletion. So therefore, I personally think this is a patient group which should be treated as soon as the drug is available with ABT-199. But of course, if the drug is working so well, the question is why shouldn't we treat every patient with the drug? This is very difficult, and we will need
Issues applied in Ecuador. The majority of the study patients had received multiple previous treatments, and 89% had poor prognostic clinical or genetic features. Venetoclax was active at all dose levels. Clinical tumor-lysis syndrome occurred in 3 of 66 patients in the dose escalation cohort, with one death. After adjustment to the dose escalation schedule, clinical tumor-lysis syndrome did not occur in any of the 60 patients in the expansion cohort.
So venetoclax is a drug that's not yet approved by the FDA for treatment of CLL. There's more and more data that we're hearing about. There's quite a bit of data, I think, that's being reported here at ASH 2015. I know, Dr. Ma, you've had a lot of experience, and you have an abstract that you're updating at this meeting. I wonder if you could comment first on the mechanism of action of venetoclax, and then perhaps give us a summary of your updated data that you're presenting here.
Right, yeah. So venetoclax is a BCL2 inhibitor because BCL2 is an important anti-apoptotic protein that's overexpressed in many cancer cells that allow the cancer cells to survive. So by blocking the BCL2, you can induce the apoptosis initiation. And venetoclax is orally available selected BCL2 inhibitor that has been studied, previously reported in the relapsed refractory CLL patients that has a very high response rate. In this ASH meeting 2015, there are two interesting studies. One is venetoclax single agent in 17p deletion CLL patients, that's a relapsed refractory group. So in this phase 2 study, the overall response rate is reported to be 80%, and the complete response rate was 10%. The 12-month progression-free survival was 72%. So you can see that monotherapy with venetoclax can induce a deep and durable response. And then I'm going to report a updated analysis on our phase 1b study in combination of venetoclax with rituximab. So this is also in the group of patients with relapsed and refractory CLL. In this group of patients, we have noticed an overall response rate of 86% with a complete response of 47%. And more importantly, 55% of all patients achieve an MRD negative bone marrow response, so very deep response. And we have also looked at the progression-free survival and overall survival. So at a 24-month analysis, so about 86% of patients are free from progression. of disease. Another interesting phenomenon is that when you look at the duration of response based on MRD analysis, none of the MRD negative patients actually have progressed at an 18-month mark, whereas MRD positive patients, about 75% of patients are free from progression. So this is regardless of the qualitative response. If you have an MRD negative PR, you can also actually be free from progression at 18-month analysis. In this study, another interesting thing is for oral agents, as we have talked about with the BCR inhibitors, is advised for patients to continue on having continuous treatment. But with a very deep response we're achieving with the venetoclax therapy, we're asking the question, can patient actually stop treatment and still maintain the response? So far we had 11 patients who have stopped venetoclax therapy after achieving either a CR or MRD negative PR. And only 2 of those patients have progressed after 24 months after off therapy. And both of those patients were MRD positive patients. So I think the bottom line is that achieving MRD negative, very deep response does seem to allow the patient the chance to possibly get out of the treatment and still remain in remission.
I think it's very important. I mean, some of those patients were our patients, and I think that the idea that if you could stop the drug and have the patient do well after stopping the drug is actually very exciting for many patients. Having a limited, finite course of treatment, it may be possible if you obtain a deep remission. We had discussions with patients, and obviously some who had achieved either an MRD negative CR or just a deep CR wished to consider going off treatment and following them longer than they've been on therapy, and they still are doing very well. So that's encouraging, I think, because it may indicate that we don't have to continually treat patients with these agents, and may devise regimens that could be a shorter-term reaction. We're now addressing the question of some of these patients who are now just beginning to show some progression after being observed for years now, whether they can be retreated with the drug and whether they can achieve a very good response the next go-around. I think they will be able to.
I think as we finish up, maybe Dr. Ferriello, you can comment us to just on the issue of tolerability and what are the side effects that we've worried about with venetoclax and how are we addressing this?
Yes, the main concern for venetoclax are actually very different from the one of the agent, the small molecule inhibitor we have talked before. There has to be great attention to the risk for tumor lysis syndrome. Patients need to be undergoing prophylaxis for tumor lysis syndrome. They need to be hydrated, and their laboratory values need to be monitored very closely because of the risk of life-threatening hyperkalemia related to this agent. Another toxicity that venetoclax has is myelosuppression. We do see often myelosuppression, mostly neutropenia. It's a neutropenia that does respond to treatment with growth factor, however, is present, can be persisting, and to some extent there is also thrombocytopenia.
Conclusion: selective targeting of BCL2 with venetoclax have a manageable safety profile and induce substantial response in patients with relapsed CLL or SLL, including those with poor prognostic features.
Of a new agent, adding it to standard therapy in patients who are relapsed or refractory with chronic lymphocytic leukemia. Why were you looking at this particular new agent, and what was the outlook? It's been difficult to add to standard therapy up to now, hasn't it?
So the new agent that we've done the trial with is a drug called Venetoclax, formerly known as ABT199, and it's a targeted drug, oral medication taken daily. The target is the protein BCL2. BCL2, as we know, is crucial for the survival of many blood cells, particularly in the survival of chronic lymphocytic leukemia cells. So the hypothesis was that if we added venetoclax combination with rituximab, that we would get more efficacy than we would see with venetoclax alone, rituximab alone, with relapsed chronic lymphocytic leukemia.
So could you describe the study to me?
So it's a phase 1b study. It was a dose-finding study between 200 milligrams per day and 600 milligrams. day of Venetoclax, but each dose level was active in combination with rituximab, and so for the presentation in EHA, combined all 49 patients for the efficacy.
And what happened?
49 patients with relapsed or refractory CLL entered the trial. 41 out of 49 achieved an objective response. Impressively, 20 out of 49 achieved a complete remission. And even more impressively, 13 people achieved a minimal residual disease negative.
Now, how much of that was due to the rituximab and how much to the venetoclax?
Rituximab typically has a response rate of about 20%, no one getting complete remissions. Venetoclax on its own achieves a complete remission rate around the 20% range and an overall response rate in the high 70%. So most of the activity relates to Venetoclax, but comparing between single-arm trials, it looks to be that there's additive effect of rituximab to the Venetoclax, particularly in terms of the depth of response.
Were there any added toxicities?
So we saw no added toxicities when we added the two agents together, and of course we saw the toxicities with single agents.
And what do you make of these findings then?
I think this is an important first step towards working out how best to use a BCL2 inhibitor like Venetoclax. This provides strong evidence that you can combine it with another targeted agent such as rituximab. The depth and durability of the responses suggests that this may be a step towards providing very good long-term outcomes for people who currently have poor outcomes.
Indeed, some of your patients didn't have to continue treatment.
6 patients who achieved complete remission actually interrupted therapy and remained on the study. The median follow-up on those patients is about 1.5 years. To date, 5 of the 6 patients remain in complete remission. Only 1 patient has had an asymptomatic indolent progression, and that was at the 2-year mark of their medication.
What are you doing about the tumor lysis syndrome? Because the drug's so effective, it can cause a problem.
Early on in the clinical development of Venetoclax, we had problems with tumor lysis. Typically, that was associated with using a dose of 50 milligrams or higher as the first dose given to patients with disease. We've learned that we can start with 20 milligrams and build up on a weekly ramp-up schedule to the target dose of 400